Hey guys, this is Greg McKettrick. I am the Men's Health Clinical Liaison for Revelation Pharma, and this is my presentation on men's health for Clomiphene, and I'm adding Enclomiphene as well. These are our legal disclaimers you can read through. Um, Hoping to cover on this are some basics about hypogonadism and testosterone replacement therapy, and then a bit of an explanation on some of these options like Clomiphene, um, what it's for, and then how it's used for men for both uh, treating of low testosterone infertility, and then the differences with clomiphene and enclomiphene, and particularly the importance of this because they are really great options for maintaining fertility along with improving testosterone. Then we'll talk a little bit about the economics. So, getting right into it, male hypogonadism and testosterone replacement therapy. Um, it's very prevalent. It's a huge concern for many men and many men of all ages. Actually, we're seeing um, much younger populations of men now are suffering from low T due to a lot of issues, comorbidities, obesity, diabetes, and lifestyle in general. So, what are the common symptoms? Well, muscle mass, bone loss, um, reduction in facial and body hair, low energy, low libido, and in cases you get into infertility, and certainly it is part and parcel with erectile dysfunction. So diagnosis and treatment of low T before we're initiating therapy need to figure out if it's a primary hypogonadism stemming from the testicles or secondary dealing with more the pituitary and hypothalamus. So common therapeutic approaches have always been using the androgenics, the exogenous testosterone or steroid therapies. Um, Most common are testosterone injections, and then the topicals and the implanted pellets. Regardless, most patients do see improvement when they're using TRT, um, reduction of symptoms and improvement in quality of life. So, the whole point to this presentation is that, sometimes using the exogenous testosterone isn't the best option for patients. And this is of primary focus with younger population of patients or men who want to still have family. They want to preserve and promote their fertility. So you need to keep that in mind, and definitely that's an intake question for patients before starting therapy. And this is because, one side effect of testosterone therapy can be infertility. We see a definite reduction in follicle stimulating hormone, FSH, which reduces the production of sperm. So it's really kind of a belief that the shots and pellets have bigger impact on fertility, but we know that really any form of of testosterone therapy can disrupt the hormone balance and cause a reduction in sperm count. In many cases, even after prolonged TRT, we can restore fertility. It's time consuming, it takes a lot of therapy, but there's also a lot of cases where we cannot restore fertility after TRT. So for men who are still interested in having kids, or they want to preserve their fertility, they want to prevent testicular atrophy, what kind of options can we look to? So options that will boost testosterone without impairing sperm production. And less common options, but included in the list are aromatase inhibitors like anastrozole and letrozole, More common, HCG or human chorionic gonadotropins, and then the SERMs or selective estrogen receptor modulators. So Clomiphene and now Enclomiphene as well. So aromatase inhibitors, they increase the testosterone to estrogen ratio by blocking the aromatization. Levels of LH and FSH and testosterone are increased because of this. So studies show that the measurables, the biochemical parameters improve. That does not necessarily mean that we're seeing all of the best effects coming out of this. So clinical endpoints, including the psychological and body composition issues, are not necessarily met. So some correlations to the impact of the reduction in estradiol having significant effect on these endpoints. Typical dosing for these types can be very low as opposed to what the trade products are. We don't have to use a milligram of anastrozole. Using very low doses, 0.1 to 0.5 milligrams a couple of times a week, typically gets the response that we need. Letrozole, a little bit higher dose, 2.5 milligrams, usually several times a week, up to every day, not common for our purposes here. So getting into the more common therapies here. So HCG, or the human chorionic gonadotropin. So adult onset hypogonadism, it's a disruption in the central endocrine axis. And HCG works in a similar way as luteinizing hormone in this pathway. So pituitaries of older patients still have the capacity to respond to gonadotropins despite lower baseline levels and surges from the hypothalamus. ACG as kind of a single entity or a standalone therapy can increase the intratesticular testosterone levels, which in turn leads to gains in FSH. However, ACG in and of itself may not really give the increased sperm level that we're looking for, indicating that we really need to have that FSH stimulation for normal spermatogenesis. HCG will increase testosterone levels and has less impact on estrogen than using traditional TRT, and can in some cases be used along with TRT when you're trying to protect testicular function and even prevent atrophy. Now, HCG dosing is really kind of all over the board. It depends on the level of the patient's condition. Are we looking to maintain testicular function or kickstart it? So, in the moderate levels where we want to kind of boost testicular function or maintain it while on TRT, anywhere from 500 units a week up to 1,000 units a week is not uncommon. But when we're going for really the restoration of testicular function and fertility, typically again due to some disease state or treatment or prolonged use of hormones, high doses where we're into the thousands of units multiple times a week are typically necessary for that. So another option for maintaining fertility or promoting fertility and boosting testosterone are the SERMs, or selective estrogen receptor modulators, and they function by blocking negative feedback of the estrogen on the hypothalamus, which causes increased LH production and stimulates FSH release, which in turn stimulates testosterone production. Common products here in your serum family, the clomiphene citrate and clomiphene citrate, and to a lesser degree, the tamoxifen. We're going to focus on clomiphene and clomiphene for our purposes. So clomiphene citrate, which has been listed under the trade names of Clomid and previously Seraphin, which no longer is available. It's an estrogen antagonist and brought to market and approved by the FDA for treatment of anovulatory or oligoovulatory infertility, usually due to polycystic ovary syndrome, PCOS, in women, and again, designed as a fertility-inducing product or ovulation-inducing drug. Off-label uses, though, and again, for clomiphene for male infertility and hypogonadism, though as early as the 1970s, it was found that clomiphene actually increased pregnancy rates by 40% when they used it to treat subfertile or hypothetically infertile men. So clomiphene citrate works again as an agonist on the estrogen in the pituitary gland, and this gives you the benefits of boosting testosterone and also increase sperm production in the testicles. The clomiphene initially was used for men with infertility and has taken on kind of a new, bigger, better role with treatment of hypogonadism to increase testosterone production. Unlike using testosterone or TRT, clomiphene does not suppress the endogenous gonadotropin secretion, which, this way we protect gonadal function and prevent atrophy or testicular atrophy, so we maintain testicular size. It should be noted that it is probably not the best choice if a patient has naturally elevated LH levels. They won't get the same gain, and this points more to some adrenal issues. So due to the combined effect, clomiphene really has this character. It's an ideal therapy for men with low T or low T and subnormal sperm counts, or men who need to bump their T but want to preserve fertility. And on top of this, patients on clomiphene, they really didn't get all of the negative side effects that you see with traditional TRT. So, the increases in hemoglobin and hematocrit, potential rise of PSA, and the lipid profile. But we still got the positives. We got bone density, we got muscle mass, and again, brain fog, improving the cognitive function. So dosing of clomiphene, it can be as low as 12.5 milligrams. More traditionally, it's either 25 milligrams a day or 50 milligrams every other day, but it does follow kind of a long range, and for short duration therapies can be considerably higher. Not typical, and again, we probably won't see that a whole bunch. The thing about clomiphene, it's actually a mixture of two diastereoisomers. So we have zooclomiphene, which this makes up roughly a third, or 38% of the total, has an extremely long half-life. It's a 30-day half-life. And then Enclomiphene, which compromises the rest of the 62%, or roughly two-thirds, much shorter half-life, only 10 hours. So you can see it's kind of a mixed bag there. So the common side effects with clomiphene, you get the mood change. You do get some potential for chills and sweats, headache, nausea, bloating, potential gynecomastia. Less common side effects, but more important, potential for some visual changes. This can be something that you really need to focus on and make sure that you're warning patients, because as soon as it's noted, you need to stop the medication. It's thought that this has to do uh, with that long half-life affecting the pituitary. So clomiphene is relatively really a safe and very effective option for management of testosterone deficiency, especially for younger men where fertility is a big concern. And I typically look at, once you get over 50, this may be an augmentative type therapy, but probably not going to be first line anymore. But pretty much anybody under that. So that brings us to Enclomiphene, which is like my favorite dog in the fight these days. Enclomiphene is the trans isomer of clomiphene citrate. So again, no longer have that long half-life zooclomiphene. Um, there are no commercial versions of enclomiphene in the United States. There was one that was going through clinical trials. It got to phase 3. This is back about 10 years ago, and company Repros just the FDA was changing some of their requirements in terms of phase 3, and it got to that point where and Repros just did not resubmit. The drug was going to be named Andraxol, but it never made it to market. So how do you get it? You get it through compounding pharmacies. Um, it has been shown to raise the testosterone and gonadotropin levels while preserving spermatogenesis. Um, it provides the androgenetic effects of the clomiphene citrate, but it has a much lower side effect profile. And again, this kind of stems back to that half-life. So we really are able to preserve the fertility through stimulation of LH and increased release of FSH, which in turn leads to increase in testosterone. And as far as the dosing of the enclomiphene, it's almost like just cutting clomiphene in half. So starting at 6.25 milligrams a day, going up to 25 milligrams a day. So again, just a real nice option, being cleaner and more potent. So, what is it important? Why do we look at these alternatives to testosterone replacement therapy? The main thing is, the TRT can suppress that hypothalamic pituitary gonadal axis, um, and this is going to cause a reduction in sperm production and lead to infertility. So, spontaneous recovery or turning that switch back on after starting TRT, it is possible. We can do it for a lot of people, not everybody. This is not a given, but it can take months and spontaneous meaning without treatment, months to years, and sometimes not at all. To address that and hopefully correct it, we see the use of these same compounds, HCG, and as I mentioned, great for maintaining or inducing spermatogenesis. Um, Much higher dosage if we're looking for this rescue type of therapy. So for protection of the fertility in that 500 to 1,000 range, maybe. Once you get up into having to kind of kickstart and flip that switch back on, it's 5,000 units a week or more. Sometimes we can actually combine HCG with clomiphene or enclomiphene, and the reason here is you get more FSH effect when you combine with the SERMs. And we know, like I mentioned before, the clomiphene citrate's been used for a long time for treating men with low fertility, and it's shown to really normalize that uh, hypothalamic pituitary gonadal axis and kind of turn back on spermatogenesis, in addition to boosting testosterone. And with with these medicines, we do see a fairly rapid increase. So, seeing significant numbers in terms of lab tests um, within 2 to 3 months is expected. Might start getting some symptomatic response even sooner, but really seeing the substance in terms of the numbers takes a little longer. And again, similarly here, you see the dosage like we had mentioned before. And here is kind of the nuts and bolts of this. So when we're using exogenous testosterone, we are blocking the releasing hormone, gonadotropin releasing hormone. So, we're shutting down the initiation of this process, um, and we're really shutting down the release and production of LH and FSH, which in turn shuts off testicular function. So you're not getting sperm production, and you're seeing a reduction in natural or endogenous testosterone. Now here you can see the effects of the medications that we're working with today. So you see with aromatase inhibitors, what are we doing? We're kind of blocking that change, the aromatization from testosterone to estradiol. Now the SERMs, or the clomiphene and enclomiphene, we are getting in there and we are acting as an agonist against that estradiol, so it's not going to affect the LH and FSH. And then you can see with the HCG, it's stimulating LH. Oh, they work in different ways. Yes, they're all kind of working towards the same direction, but there's benefits to each and some more. So again, in terms of maintenance and restoration of spermatogenesis and fertility, either during or after testosterone therapy, like I said, kind of my big dog in the fight these days is Enclomiphene. So it is the trans isomer from clomiphene citrate. It's really purely anti-estrogenic in its effect. It's short half-life, much shorter half-life than clomiphene. You boost LH and FSH. You are maintaining that spermatogenesis. All doses of enclomiphene, even very low doses, have been shown to boost testosterone levels. So even using the 6.25, now it may take longer, but with a dose response, we can see starting to see the beginning of changes within the first couple of weeks, and then really seeing the difference within 2 to 3 months. And again, here's the stated doses. Most commonly 12.5 and 25 milligrams a day. And again, the reason that I love the enclomiphene is just because it's so much cleaner than clomiphene. The side effect profile, the potency, why pick one that's got some negatives to it when you've got one that really is just very positive? And for anybody who's wondering, this is kind of I think a great description. This is actually studies that were done comparing enclomiphene to testim, or testosterone gel, and they showed an equivalent testosterone response between 25 milligrams of enclomiphene a day, and the testim gel applied once daily. So I think that's really significant. And it's a great way, especially when we're talking to patients and prescribers who may think that, this is like maybe this is an okay way, but not the best. I mean, I really think this emphasizes what the importance is. Here you can see um, some of the percent changes in terms of the testosterone levels within the system. Again, from the color changes here, you can see the gel is that kind of fuchsia color, and then the dosages of the enclomiphene And you can see where there's substantial response from really both the 12.5 and 25, but even the 6.25, you really can see where that boost is evident. And here we see the comparison in terms of LH. So again, what's the big deal with this? Well, we're maintaining function as opposed to using the testosterone. So not only are we getting the numbers that we want, we're getting the positive benefits of testosterone therapy, but we're also preserving our function and maintaining fertility. And I think these graphs just go a long way to highlight that. Okay, here's the fun stuff: dollars and cents. Um, so I think as we've kind of gone through, there's some significant benefits health-wise, pharmacologically. But like everything else, a lot of stuff comes down to dollars and cents for patients. Clomiphene citrate. Commercially, we used to have generic by Pharmaceutics, but no more. Um, so now it's just Clomid, 50 milligram tablets. And Clomid for 30 tablets, this is wholesale price. Wholesale price is over $200. Retail prices, best case scenario, well over $100 for a month's supply. In a lot of cases, double that. And again, main reason for this is that Pharmaceuticals, they just dropped the generic Clomiphene over a year ago now. So no more. The compounded version of Clomiphene is still, we still compound this and it's available, and it's a lot more affordable. So an equivalent product. So, the Clomid is a 50 milligram tablet, 30 tablets, which pricing you saw. So kind of to make it apples to apples, for 60 of the Clomiphene, the compounded Clomiphene, 25 milligram through Revelation, it's $65. You can see that's a great savings for patients. HCG, well, HCG used to be able to compound it, but the FDA recategorized it as a biologic agent, so no more. There are trade products available. Pregnil, Novaril, and Ovidrel are still out there. And, depending on what the patient's dose is, these vials typically are 5,000 to 10,000 units per vial. Pregnil is the least expensive option. It does come as a 10,000 unit vial. And if you recall going through kind of some of those dosage schemes, you could end up having to use several vials a month, depending on what your course of therapy is. And keep in mind also, even if you're not using as much, this is, it's a sterile product. It has to be reconstituted, it has to be refrigerated. And once you pierce that vial, your sand dial is going away. You're starting that time clock, the timer on it. So you're only going to get a month out of the vial before you have to discard it. And this stuff is pretty expensive. Again, for one vial of Pregnil, it's almost $170. Retail prices can be, again, with discounts, maybe just under $300, without over $400. I will say we've got great pricing on this, guys. The Revelation price on this is $199. Oh, probably as cheap as any place anybody's going to find it. Again, my favorite, Enclomiphene. So there are no commercial products available. And I mentioned before that we can compound it, and the reason we can is because it is listed as a Category 1 on the FDA bulk substance list. Pricing, again, through Revelation. So if you're on the 12.5 milligram, you can see there 30 is $58, 60, 78. the 25s, 30s, 88, and 60s, 98. So it's a little more expensive than the Clomiphene, but honestly, for the little bit more money, having the fact that it has a much better side effect profile and the potency factors are better, I'd stick with it. I am threw in here the aromatase inhibitors as well. And I mentioned earlier that the trade products like the anastrozole 1 milligram, we hardly ever are we going to be needing that high of a dose. Um, but it's out there, it's available, and they're not very expensive. Um, really quite cheap generically. So there are options if patients want to do it. Might need to split some tablets up. Compounded wise, um, again, relatively low dosing. And again, with compounding, it's going to cost more, but ease of dose, not having to worry about breaking and losing tablets and consistency in what the dose is. So probably looking at about $60 a month for the anastrozole. Oh, kind of wrapping things up. Um, the information presented here. I know really this was originally supposed to be a presentation on clomiphene, but since we have introduced Enclomiphene, man, I really wanted to include that in the presentation. I think the SERMs are great. I think they offer some really different therapeutic options. They do overlap, of course, with testosterone therapy or things like the HCG and even aromatase inhibitors. Um, but the augmentation therapy with TRT is a great bonus. Being able to address aromatization, but the standalone, I think is huge for us. We can address so many patients in a more natural way with maintaining natural function, preventing infertility, preventing atrophy. Oh, again, really, I think it's important for us to educate our patient populations and our prescribers as well. And again, availability of the SERMs, especially in Clomiphene, guys, for patients that want to maintain fertility, they need to boost their testosterone level. I think this is a therapy that, as a first line choice, it deserves a lot more consideration. Like I said, it's kind of my favorite dog in the fight at this point. So, with that, thank you for your time. Hope you enjoyed it. Reference page, reference page. That's how you reach us. And that is us. Woohoo. All right. Thanks, guys. Y'all have a great month.